Assalamu alaikum friends. Welcome to my channel Orthopedics Made Easy. I want to remind you before starting the proper topic why my videos are important. They are precise and exam oriented, and it's a very simple and interesting presentation, and only one topic is covered in each video. So you can see any topic of your interest anytime without searching much. So please like, share, and subscribe to my channel. We'll move on to the topics today. So we have a clinically very important topic, but not commonly kept in your exam. So what it is? So we'll start with the history for today's case. So we have 25-year-old male patient. He has history of fall and he sustained shoulder injury after the fall. So on doing X-ray, X-ray was normal. So X-ray was normal means there was no any bony injury at the time of injury. But the patient complains of absent of overhead abduction. Absent of overhead abduction means patient is having some problem with muscles involved in shoulder abduction. Okay, so with this brief history, we can conclude that patient is having no fracture as such, but there is some soft tissue injury involving the muscles, which is responsible for shoulder abduction. So this is the mechanism of injury: direct fall over the ground and contact with the shoulder. So it's a direct shoulder injury. So there is due to this direct shoulder injury, patient is having injury to the muscle structures, which is responsible for abduction of the shoulder joint. So today we are dealing about rotator cuff injury. It's very important for the shoulder movement, and very rarely it is asked in your practical or theory examination. Okay, so rotator cuff are one of the very common source of shoulder pain and decreased movement around the shoulder joint. So before going to the disease process, we need to recall our anatomy. So in anatomy, we need to know what exactly the shoulder rotator cuff is. If you see here, this is the proximal humerus, this is the glenoid. So, and if you see, this is spinous process of scapula. So we have supraspinatus, infraspinatus, and teres minor here. And anteriorly, we have subscapularis. This is subscapularis. So all these three muscles. So if you go, if this is your shoulder joint, this is anterior, this is posterior. So we have four muscles here: subscapularis, supraspinatus, infraspinatus, and teres minor. So these four muscles form the rotator cuff. And out of that, the supraspinatus. Supraspinatus is very important because it is responsible for abduction, whereas the anterior muscles, they are responsible for internal rotation, and posterior muscles, they are important for external rotation, whereas supraspinatus, it is mainly responsible for abduction. So this four rotator cuff you need to remember. And the second thing is, if you see the rotator cuff, this side will be the articular margin. As I saw here, this is articular margin, articular surface, and here we have a bursa. This is the bursal surface. So we have bursal surface of the rotator cuff and articular surface of the rotator cuff. So depending on the amount of involvement of the rotator cuff, we have complete tear. Complete tear means there is complete discontinuity of the rotator cuff. If you see here, the rotator cuff is completely disturbed. So it is a complete tear. Or we can have a partial tear. The half of the rotator cuff can be damaged or injured. So it may happen over the bursal surface here, it may happen over the joint surface here, or it may happen inside the interstitial intra-substance of the supraspinatus. So we have here, if you see, there is a tear over the bursal side. Here, if you see the tear over here, tear over the articular side, this is over the bursal side, and this is interstitial tear. So we can have partial tear, which may be towards the articular surface, towards the bursal side, or in the interstitium of the muscle tissue. So this is how we classify rotator cuff. So in this slide, you just need to have orientation how rotator cuff. So anteriorly, we have subscapularis, superiorly supraspinatus, posteriorly, we have infraspinatus and teres minor. So posterior external rotation, anterior internal rotation, superior in the form of abduction. So this is a little about the shoulder orientation. So if you see, this is the chest to surface transverse. So shoulder is not horizontal, same in line with the chest. So shoulder is how it's inclined to the chest surface. So this is shoulder line. So this is the inclination we have when compared to the chest wall. So any movement happening is perpendicular to this axis. This is the shoulder axis. So movements are perpendicular to this axis are happening. So we call this movement here flexion, this extension. Okay. Here the movement here is adduction, movement here is abduction. So if you see here, this is your shoulder joint. Okay. This is glenoid and humerus. So this is the axis. So the movement perpendicular means movement going like this is flexion. Movement going away is extension. Okay, if you see here, my cursor is not, if you are seeing the patient here, this is the shoulder joint, this is humerus. So the movement this way is flexion, movement this way is extension. Okay, this is perpendicular to this joint line. So the same way, if the movement this way is adduction, this way going is abduction above. So here, if you see, this is flexion and extension. So it's a perpendicular to the movement are in this direction. Flexion, extension. So the same way it is inside and outside, this is adduction and this is abduction. Okay, then circumduction, the rotation is this way. External rotation is this way. So just here, one point you need to remember is the shoulder is not in line with the transverse section of the body. It is inclined towards the transverse section. So the movements are happening in perpendicular to the joint line. So we have the following movement. We have flexion, as I told, extension, adduction, abduction, external, internal rotation, and circumduction. So the important thing here we need to remember is uh, shoulder abduction. Shoulder abduction is very important. Why shoulder abduction is very important? So we have three grades, three angles in the abduction. One is 0 to 15 degree. Second is 15 to 90 degree, and third is more than 90 degree. So these two men, they are acting at the shoulder joint. Whereas this moment, it is acting as scapulothoracic joint. So if you see here, first 0 to 15 degree, it happens by rotator cuff. Okay, then 15 to 90 degree by deltoid and over the 90 degree by scapulothoracic movement. So any damage to the rotator cuff, the initial 0 to 15 degree is not possible. Then after that, once patient give assistance for the lifting, then after that he can move further. So 0 to 15 degree is by rotator cuff. This is one important thing you need to remember. So again, to repeat, we have 0 to 15 degree by rotator cuff, 15 to 90 degree by deltoid, and remaining is by scapulothoracic movement. So any injury to the rotator cuff will hamper the movement in the beginning, that is 0 to 15 degree. 0 to 15 degree movement is very painful and it affects when there is an injury to the rotator cuff. So how will you classify depending on the duration? I mean the presentation of patient to you after the injury. We have two. One is acute tear. So immediately after the injury, patient is having injury to the rotator cuff. So it may be a direct shoulder injury or following shoulder dislocation. The chronic tear is patient has some degenerative process going inside the body, like subacromial impingement, arthritis of the shoulder joint. A patient is having other metabolic disease which are responsible for tendinopathy, like gout, rheumatoid arthritis, etc. They may cause a decrease in the strength of the rotator cuff and cause damage to it. So we can have acute tear and the chronic tear. What are the risk factors? Higher age, smoking, there is increased tendency of having rotator cuff, hypercholesterol, and family history. So what are the clinical features? We can have trauma in acute injury, no trauma in chronic or subacute presentations. Patient will have weakness. Weakness all over the shoulder? No, it is the weakness from 0 to 15 degree. Initial 15 degree abduction, it is not possible. So once somebody gives support till 15 degrees, after that patient is able to lift it up. So here there is one terminology called as abduction paradox. It is not important for you, but for PGs, it's very important. What is abduction paradox is when patient is doing abduction, patient is able to do abduction after first 15 degree of abduction. Then with the after the abduction, when the limb is coming down, once it reaches 15 degree, patient lose hold over the control and suddenly it falls down. This is called as abduction paradox. So I don't think it is important for you. So if you can remember one terminology, it's a abduction paradox. Patient will have pain and patient is having restricted overhead abduction because patient is having problem with initiation of abduction. So how will you diagnose it? We can take X-ray. To rule out any arthritic changes or any bony injuries after the acute trauma. Ultrasound is very helpful in because we can see the rotator cuff in ultrasound very nicely. And if you are still suspecting some other pathology along with the rotator cuff, we can do MRI of the shoulder joint. So here there is one old investigation. It is called as arthrogram. You need to remember what exactly the arthrogram is. Arthrogram is taking the X-ray, but before taking X-ray, you are injecting a radio opaque dye to demark the borders of the joint or the any problem inside the joint. So it's now after initiation of MRI or discovery of MRI, arthrogram is not being done now. But if you remember arthrogram, it is what means we are injecting the radiopaque dye. This all white is the dye inside the shoulder joint. If you see some of the dyes, it breached through the rotator cuff and entered into the subacromium space. So this indicates that patient is having some discontinuity here, which is allowing the dye to come out of the joint. So this is a contrast X-ray. Contrast X-ray is arthrogram. Okay, once we have diagnosed, what is the treatment? Treatment is first we need to give rest and NSAIDs to decrease the pain. Physiotherapy also can be done. Initially, it will be very helpful in cases of chronic tear following degenerative pathology. So deltoid strengthening exercise and all we can do. Or if the patient is having acute tear, we can do for repair. So here, if you see, this is how we repair it. Patient is having cut here, we have repaired it with using some uh, suture material and fix it to the bone. So suture anchors and suture material. So this is repair. Or what we can do is tendon transfer. When the patient is coming with a chronic tear and the tendon is completely damaged, what we can do is we can harvest the tendon, we can harvest the trapezium muscles or other muscles around the scapula. We'll redirect it and insert it over this one. This is called as tendon transfer. Tendon transfer. Then arthroplasty is the final treatment if patient is having arthritis. So what happens if you won't treat rotator cuff? So patient may have arthritis of the shoulder joint. Second thing is rotator cuff arthropathy. It's a very simple thing to understand what is rotator cuff arthropathy. If you see here, there is a tear in the supraspinatus. So this supraspinatus try to push the shoulder down, but that is gone. So what happens is shoulder is moving up and it is articulating with the this is clavicle and acromioclavicular joint. So over the period of the time, this will get distracted and this will get distracted. So if you see here, this is a normal shoulder joint. There is a space between acromioclavicular joint and the upper border of the shoulder humerus. Here, what is happening is this space is nothing but your rotator cuff. So once this rotator cuff is gone, this is moving proximally and causing damage to the articular surface. So this is called as rotator cuff arthropathy. So what is the treatment for rotator cuff arthropathy? We need to go for replacement. That is called as arthroplasty. So what is the type of arthroplasty and all? It is out of subject for you. So you just remember there is a treatment for rotator cuff arthropathy. We need to treat it by arthroplasty. This is all about today's topic, that is rotator cuff pathology. Thank you.